looked at improving granularity. And one of the F4 patients, they show you that how that F4 patients had, for instance, 96% of his tissue is F4 and the left 34% F3, versus another patient, they had about 60% F4 and the rest is 30% F3 and some F2. In that way, they're showing you that F4 patients, for instance, are not graded equally. So now you have, instead of doing transgenital liver biopsy, a way by doing machine learning on histology, by doing certain score, looking at nodules and septan, combining a score to predict portal pressure. Of course, you need validation, but how nice is that the portal pressures, you don't need to do them anymore, and the machine learning are predicting that.
Hi, this is Roger Green, host of the Surfing the NASH Tsunami podcast. Over the next few days, we are offering 3 conversations from episode 62, the first of our 3-part year-end series. The episodes offered shortened conversations with our opinion leaders. This piece shares our entire conversation with Mazen Noureddin on how artificial intelligence and pathohistology progressed in 2021 and where it is headed in the years ahead. This conversation represents a candid, detailed discussion with a major opinion leader on a subject he discusses passionately. So sit back, listen, enjoy, learn. And when you're done, join the discussion on our LinkedIn and Facebook discussion groups. So this chapter of our 2021 year-end interviews is with our good friend Mazen Noureddin. Mazen, how are you today?
I'm very good. How are you?
I'm fine. Mazen actually, turns out, is batching it until the end of the year. His wife and children are overseas with her family, and he is at home by himself. We're hoping he will eat reasonably well, drink moderately, and take good care of himself. We also, as we will for all these interviews, have Louise with us. Hey, Louise, how are you doing this afternoon?
Very well, thank you very much. Nice to be here.
I watched Louise do a 10-minute practicum on how to use her computer. We were having a hard time getting her mic and audio set up, but she went into the guts of her software, figured the whole thing out.
Oh, some AI I can do, but it takes a while.
I was going to have one of those lines about did all that while whipping up a souffle and standing on one leg, but we don't have to go there tonight. So the format for these year-end interviews is pretty straightforward, which is we've got a topic, it's a broad topic, and we will allow whoever our host is to decide how she or he would like to handle it. The topic we handed Mazen was to ask about advances in AI and or cost effectiveness in the last year. Those two subjects don't seem to lump together, but they're both things Mazen knows a bunch about. So the format's really simple. What have we learned in the past year? What do we expect to learn in the next year? And he'll talk and we'll ask questions, and there'll probably be jokes and merriment along the way. Mazen, why don't you just kick us off? So what do you want to talk about within that range?
There will not be a lot of jokes. It's a rainy day and my kids are away, so it's going to be a serious day. And by the way, I'm not alone. My parents live with me. Let's dive in. What I want to say about AI, it's a really deep field, and we're really just at the surface in hepatology. There are a couple of good papers that are review papers, one from the Mayo Clinic that was published, a very nice comprehensive review that I will direct you to. We wrote a short one as well in hepatology about AI. As I mentioned, AI is a very deep field and we're at the very surface. But in general, AI, you want to think about it as 2 big things: machine learning and deep learning. An example of the deep learning, what you hear about the CNN, not the news channel, but the convolutional neural network that, for instance, the Path AI came from. And machine learning, there are many, many examples. So I don't want to dig deep. I'll direct you to these reviews that they were published in hepatology, but it's a really evolution field that we're still learning, we're trying to learn, we're submitting papers, and we still get asked questions that you can tell people are still learning what is AI, because it's totally different field in terms of what you present, what's the training cohort, what's the validation cohort, how you present data, yada yada. The AI can really touch every aspect in science. But the most interesting aspect in hepatology on how to improve diagnostics, right? That's what we are trying to improve our ability in, especially in the field of NASH. And the most important areas are the following: the diagnostics using non-invasive testing and histology. And what we have seen the most progress in the last year was the improvement in the histology. I think we will see more coming in the diagnostics in the next year. The reason why I say that, because most of the diagnostics were in the abstracts form, that we will see it coming in publication form in the next year. But the histology, we already saw multiple abstracts plus publications in the last year. So let me set the stage for the histology. Roger, you guys talked about this in multiple episodes, why we need that in histology. And I talked about this in the ASLD in one of the clinical workshops that Jazz Bajaj invited me to talk about. As mentioned before, histology in NASH has been an issue, and I don't want to dig deep into what's the issues to repeat previous episodes, but in a short summary, the intra and inter-observer variability has been a big problem. That happens even with experienced pathologists. Now, with experienced pathologists, it's a less a problem, but we don't have too many of those, and the NASH, as you know, it's a tsunami, which is your show, and we have multiple and many trials that are in the pipeline right now. We have thousands of patients that they're going to go through phase 3 trials, and they're going to have a biopsy that needs to be read in a proper way. I don't want to count numbers of the experienced pathologists, but they're probably not going to match that thousands in a timely fashion. So AI or machine learning in histology can be a very attractive way to match or cover multiple things or multiple gaps in conventional histology, such as the inter and intra-observer variability, improving the granularity, and I'll get to the examples of that in a second, maybe overcoming the placebo effect, and of course what I just talked about, overcoming the number of the expert hepatopathologists that we need to have. The papers that I want to point to are probably a couple of papers, but the pioneers that are leading the way in machine learning in NASH histology are HistoIndex and PathAI. There are other companies, I don't want to take away from them, but we have seen most of the publication coming or the presentation coming from HistoIndex and PathAI. So the publication I want to point out to was published by Taylor, Weiner, et al. In Hepatology in 2021, and I had a tutorial on this one, and this came actually from one of the larger randomized control trial. I don't remember which one was one of the Gilead trials, but basically what happened is Zach Goodman was the pathologist who we know is outstanding pathologist, and if you want to have a pathologist for your NASH clinical trial, Zach Goodman is one of them. And he was kind of the standard reference, if you want to call it, when he assessed steatosis, lobular inflammation, as well as ballooning, which is the pathogenic features of NASH score, and of course the fibrosis. They put them in the machine, the CNN network. They came out with the readout for the machine. And what they did in that paper, eventually they had after that a panel of 3 pathologists that they looked back at these lesions, the steatosis, inflammation, and ballooning. And what they found that if you get 3 pathologists, they had a good kappa between them reading these 3 lesions, which is great. It tells you the pathologists are great, but again, you need 3 of them to read the lesions to agree on it, which is many of them. And I go back, if you have multiple clinical trials, having 3 pathologists to agree on the lesions and the numeric reading is a lot of work. What they did after having these 3 pathologists, they used the PathAI that was based on initial Zach Goodman reading, and they looked at the correlation between these 3 pathologists reading and the PathAI. And what they found that they had a very good correlation and kappa reading between the PathAI as well as the pathologist. So this is a way that the PathAI or the machine learning method is correlating highly. I had a question yesterday that they said, well, maybe there's some error that has been made in the reading initially that the pathologist did, and the AI picked up that error. And my answer was the method was initially based on a very experienced pathologist, and if such an error was made, what the machine will do probably will capture that error, but at least it will be consistent reading that error and many other right things across clinical trials. So it will not vary across trials, if I make sense. The other thing on that trial, and I'll stop after that study in a second, what it did also, it looked at improving granularity. And what I mean by that, it was very eloquent work where they had an example of 2 F4 patients. And one of the F4 patients, they show you that how that F4 patients had, for instance, 96% of his tissue is F4 and the left 3-4% F3 versus another patient, they had about 60% F4 and the rest is 30% F3 and some F2. So in that way, they're showing you that F4 patients, for instance, are not created equally, and they show you the change in an example of change, how these patients change from F4 and F3 to F3 and F2's pre and post treatment, which is like very granular versus the conventional way, which is just one linear line looking at changes in the conventional method, which is one stage fibrosis improvement. The final two things in that paper, they were a couple of things. They created a machine learning score that they looked at one of the Gilead study, which was the Atlas study, which was not statistically significant, but the placebo rate was high. And when they used the machine learning, looking at the treatment arm as well as the placebo response, the placebo was much lower compared to the conventional therapy. And using that machine learning method, the study was statistically significant. So it makes you wonder if that's a better way. And finally, as in all study, they looked at correlation between machine learning and clinical events, clinical liver events. Although there were not too many, they did correlate the machine learning with clinical liver events, and what they used is the Gilead Stellar 3 and 4. So I thought it was a very eloquent study showing the promise of machine learning in histology, assessing different lesions in the NAS score as well as fibrosis, correlating with events, maybe mitigating the placebo effect and improving granularity. So I think it was a big step toward showing the promise of such technologies in histology. I can talk about this subsequent study that they did also trying to introduce other things to their machine learning, but I just want to give it back to you first.
Louise, you have any questions or comments?
I find that interesting listening to that in the context of the recent Intercept withdrawal with the AMA, because they're going for a complete reread from how I understood it, of their 18-month biopsies by a consensus approach. Would you be looking, therefore, to put AI? Which approach do you think, having listened to what you were saying there, would they be better doing, or would it be a combination of all to really deep dive into that information so that they can get this medication through in the best way?
Louise, that's a brilliant question. What time is it in England?
I'm obviously still awake.
You ask great questions even when you're asleep.
So why are you surprised that at any hour of the day or night, Louise would show up with a brilliant question?
No, I'm not surprised at all. She always asks a great question, but she started with one of the most important questions that we are all looking for to be implemented one day. This is the core question of this, to be honest. When are we going to apply those machine learning technologies in clinical trials, especially the registry trial? And the answer to your question is absolutely yes. I would love to see it in the regenerate trial being implemented. As you know, and I don't speak for regulatory authorities, there should be steps for them to accept machine learning as a way to accept a drug based on these machine learning methods, which my understanding, they're not there yet. To me, as patient advocate, that's what I do every day. I want to find a treatment to help my patients. 2, I'm a researcher. 3, I'm a clinician. I do have something in front of my eye that is telling me more about histology. It's more granular. It's correlating with outcome, which I understand the regulator that they're looking for mostly, which is correlating with clinical liver events. Why don't implement it now and give me a drug that will help me right now? Nevertheless, I do understand that they need to be conservative, look at it with multiple lenses, yada, yada. But at least to your point, they should do it, whether they accept it or not, as a way for their approval of drug. They should analyze it and say, hey, the conventional method that we're being held accountable for showed so-and-so, and the machine learning showed this and that. So we should start doing these kind of comparisons all along to show the field what these methods are doing.
Louise, got another question, or you want me to take the next one and then you can come back? Go ahead, please.
I did have another question. It's always seemed strange to me that we use Metavir. Everything you were detailing there was this difficulty in moving back that one stage, and we know that all F4s aren't the same. Whereas Ishak, by dividing into more categories, seems to show better, in my understanding, where you can fit in liver-related outcomes with F5, F6, and we've seen some clinical research data that splits those back into the Ishak format. So maybe we're just trying to jump too big a hoop and just use a better grading scale that allows us to see and delineate between the different levels.
Louise, do you know that song? I'm going to change it. I'm respectful. Instead of this girl on fire, I'm going to say this woman on fire. So your questions are on fire.
You can keep girl in.
I'm going to use the song. You're on fire. The questions are right on. We have had discussions among us. For instance, I had discussions. There have been discussions, internal discussions. I don't want to spell it out. For instance, in the NASH forum, I was discussing with, I don't know if I'm allowed to say, but I would say it with Arun Sanyal Naga Chalasani about we put the NASH cirrhosis paper for the NASH forum, but we're talking about various things. And one of the things we talk about, if Ishak fibrosis should be used in NASH cirrhosis clinical trials, because as you alluded, it's 1-6. It's more granular than the NAS-CRN that is being used, especially on the end spectrum when you get to 3 and above. So there has been a discussion, or have been discussions. The AI, the thing what I like about it is not just they started breaking down the same patient, the same exact patient, saying this patient has so much F4 and so much F3. And if we have time today, I'm going to get to one of the abstracts and incoming work that we started talking about nodules, number of nodules, septa thickness, fibrosis areas that we just presented in the AASLD. So there's another paper also by Professor Bush et al. That they started looking at that concept in cirrhotics. So I'll talk more about that. As a follow-up, and I'll keep going, I thought the Path AI did another great work presented by Professor Bush et al. in Hepatology in 2021. And I will also mention our work that is coming from HistoIndex that we presented at the AASLD. So Professor Bush published in Hepatology with many esteemed colleagues. What they did with the Path AI, they said, first of all, they took advantage of the simtuzumab trial. I want to emphasize on the simtuzumab, the galactin, and maybe one of the Cunadis trials. And the advantage of those is in these cirrhotic trials, they are, I think 3, if I'm missing one, could be 4, that measure portal pressures that were mainly read by 2 of the leaders in our field, Lupe Garcia et al. And Jaime Bush. The portal pressure, there were endoscopies, there were central reading, the portal pressures were harmonized, tested before the center started doing. They were not easy, they were difficult. The reason why I emphasize all that, because I don't think we'll see portal pressure studies in the future. So I congratulate the authors that they are trying to get data from such a trial. What the authors did here using AI technology is they created machine learning HVBG score because they had HVBG. What they went back to the slide and they said, well, we always look at this, line looking at fibrosis, but let's look at beyond that in patients with cirrhosis. As you know, the thickness of the septa matter a lot, the nodule size matter a lot, and fibrosis area, the more dense it is, and that has been already studied in the field of cirrhosis, like collagen content and how much collagen you have. So I'll give you an example. You have 2 compensated cirrhotic patients, but someone with thicker septa, bunch of nodules that did not have portal hypertension yet is different from someone with thinner septa and less nodule. The one with thicker septas and bunch of nodules will be harder to treat than the other one. So what these guys did, actually, they introduced the nodule here. And what they found that was such a thing in machine learning model that their score correlated with portal pressure. What did not pan out completely is that score at baseline did not correlate with clinical liver events. So again, the score at baseline did not correlate with the clinical events, but the change in the score correlated with the clinical liver events. So the change. What we did with HistoIndex, different trial, Galactin. These guys did simtuzumab. Galactin, if I remind you, was cirrhotic trial that had portal pressure endoscopies. The portal pressure read by Professor Garcia et al. And we use the same concept. And by the way, we have been working on this since 2017 or 18. So we just did not copy paste. Dr. Goodman has been working on the nodules and the septa for some time now. It started from reading a paper or reading multiple papers from Professor Garcia et al. That she published 10 years ago, and there were statement papers by her and Dr. Scott Friedman saying, well, cirrhosis, we always look at how much going from 4 to 3, but if you think about it, the architecture of cirrhosis, you need to look at the septa thickness, the nodule size, number of nodules, fibrosis area. So they did studies back then looking at these various things. Small studies from Hep B and C. They had some variation in the reading between semi-quantitative and quantitative readings, and they acknowledged these problems. They said it's probably variation in reading. So we said, well, now we have machine learning. Let's take advantage of that and do what they did in larger cohort with portal pressures and in NASH. And that's what we did. We looked at the septa thickness, features of septa, nodules, and fibrosis with many, many features, more than 200. And we correlated with portal pressures and we created scores. In our work, first of all, the septa features, the nodules features, the fibrosis features correlated nicely with the portal pressures. But if you combine them in one score, they correlated even better. So one, they correlated with the portal pressure. Then they correlated with clinically significant portal pressure, which is 10 and higher. And even beyond that, because the study had endoscopies, they correlate that score on HistoIndex score, they correlated with varices. So now you have, instead of doing transjugular liver biopsy away, by doing machine learning on histology, by doing certain score, looking at nodules and septa and combining them in a score to predict portal pressures. So, of course, we need validation, which is going to be hard because the cohorts are very minimal. But how nice is that? The portal pressures, you don't need to do them anymore, and the machine learning are predicting that. And I want to mention the last abstract actually presented by Arun Sanyal from the Novartis study when he looked at using same concept, and I'll mention one line here from Novartis study that was not statistically significant, but in the F3 patients, they looked at the septa in their studies, and he found statistical difference when they looked at the septa thickness and features such as septa in their study. So the question is, if we start using these things, is like, one, can we start replacing important stuff that is invasive in the field of hepatology with machine learning methods? And two, can we detect things that are actually changing with treatments probably conventional histology missed? And it could be that a drug is actually doing something that we are not seeing. Of course, an effective drug will show you what it's showing in a short period of time. But NASH is a long chronic disease, and sometimes you might need a longer treatment that on the long term might show changes. That drug can be combined with something else. So a lot has happened with histology and machine learning, in my opinion, in the last year. And this is just on the histological side.
Mazen, that's all great. Those are great descriptions, and Louise has asked fantastic questions, and I kind of feel like I'm the truck driver at the F1 race, but nonetheless, I'm going to.
So F0, Roger.
One of the questions.
I'm just kidding.
F0 is fine. F0 is a better race than F1, unless you're talking about driving cars. It strikes one of the things I know Steven's talked about in some of our recent episodes, and other people, is the ability to strengthen the power of a trial by having a better understanding of what patients you want to be looking at. So one of the places I thought you might be going, though you didn't say it, is if we could learn through AI that things like, for example, septa thickness were predictive of anything worth knowing, do we then start doing a better job of screening for patients that are likely to demonstrate what we're trying to demonstrate in the trial, for want of a better word? Is that a realistic future?
Let me give you some compliment. This man is on fire. Yeah, I think so. So I think
I'm just trying to live up to Louise and you.
It's a rainy day here in Los Angeles, which is unusual for us. I cannot go anywhere, so we're all in this together. So I'm here. I'm with you guys.
Oh, that makes me so happy.
So, if I'm following you correctly, Roger, I think the very immediate use of this, I see it as following. I really think a lot of people are targeting the NASH cirrhotics now, which is great. In my mind, I always say cirrhosis is a beast. Your drug really needs to have muscles to muscle that beast. When kinetics went after the decomps, I'm like, wow, that's like the beast of the beast. Like, you're really going after trouble. I mean, I congratulate them. We need something in that group. So for the compensated cirrhosis, they are not the same. And I'll quote that with literature. Between the simtuzumab and the stellars, there are different severities. And that is reflected by the number of people decompensated and the lengths that they decompensated in 2 trials. It was more on the simtuzumab. And there was a paper published by Zubair, Yunasi, and Jehab, the simtuzumabs, and they were basically enriched with what they called the cryptogenic cirrhotics. And those, they had more collagen content, which is more collagen, more fibrosis area. Probably, they didn't measure septa and all this, probably thicker septa, more nodules, yada yada. So I think the answer to yours is choosing the right patients. Eventually, we will split the patients in cirrhotic trials, the compensated cirrhotics, into even different pockets. We'll stratify them. A simple way could be what Louise mentioned by Ishak, 5 and 6, or we can go beyond that, those that the compensated cirrhotics with a lesser or more favorable, you just stratify them, that score with the thinner septa, less nodules versus thicker septa and thicker nodules. You might even exclude them if they are too hard to treat. Another one just crossed my mind that I've never thought about it. You know how we say sometimes the Falcon one is a perfect example. There was a question how many were cirrhotics. And some people thought that they're probably a good number that they could touch the cirrhosis. So if we start looking into ML learning and all that and start knowing more about the amount of collagen and septas and all this, we probably can start separating the F3 more sharply from the F4s and not get ourselves in trouble by having some cirrhotics in the F3s.
Mazen, that's great. We are at 36 minutes on a 25-minute interview, but every minute of that has been a gem, particularly the moments when you were praising our question styles. Louise, do you have anything else you want to ask? And then I have a kind of a close for our friend Mazen.
No, I think I would certainly like to see if Intercept are doing the review that they did it in Ishak and Metavir. One of the problems that the FDA had picked out was the liver-related events. And if you could split them into those 2 different groups and show a statistical difference, that to me would be important. And for me, patience. If you turn down a drug because we're asking you to jump too high, but you can split that and see a difference, that to me is not a waste of somebody's time and trial, and you may well get those drugs. It beggars to Manal's constant talking about actually cirrhosis and stabilization is an important outcome. And if you move from Ishak 6 to Ishak 5, that doesn't meet the FDA's current endpoint, but that's actually an improvement in somebody's liver in cirrhosis. And that's an important outcome to me. It's an important outcome to the patients. So it'd be really, really interesting to see how the AI, the machine learning, and Mazen's definitely convinced me that we should move back to Ishak, or certainly do both and see where our differences are, because it gets picked out all of the time. So I'm not too sure why we moved only towards the most difficult one.
Mazen, my friend, you were so persuasive today that you persuaded Louise of something you didn't even set out to persuade her of. That's pretty compelling. My last question to you, real simple. We're having the same conversation 12 months from now. What'll be different? 12 months. Next December.
In this regard, there are steady small steps we just talked about histology today. I know we're out of time. There are diagnostics in AI. We didn't talk about cost effectiveness, but in the histology, within the 12-month, I think there are good steady steps. I think you will see at least engagement between the machine learning and AI companies and the regulators to learn how they can get approval in implementing their technologies as part of clinical trials. At minimum, you'll of course see more data from them because it's shaping itself, right? You saw the nodules, you saw the septa, you saw this and that. So they are producing data, but I think what you're gonna see extra is the regulatory language that Louise was asking for with her first question. It will start appearing in the next 12 months or so. So I think they are the front line of machine learning in hepatology. And there are many other fields on diagnostics and models predicting F2 and NASH and yada yada, but they are the front line for that.
Well, the way I'm interpreting what you just said is that the first thing that will happen with AI machine learning is that it will make histology both more robust and more precise, which will do two things. It'll help us get drugs approved faster, and it will help us understand the impact of diagnostics faster because we'll be able to take the diagnostic results and lay them up against a clearer picture of what's going on in liver.
Yeah, in the next 12 months, I think we will hear what the agency will allow them to do, in which form, in which capacity, why they're spitting out their data. That doesn't necessarily, they'll say, okay, phase 3 now is by so-and-so company and so-and-so company. Well, it'll be good if they decide so, but we will hear what's their steps to be implemented eventually, which is, in my opinion, still a step. But they will help us. We're learning more from them. And again, we're improving granularity and precision.
Mazen, that's great. I will close by interpreting that last statement as a shameless plug for people to either attend NASH-TAG live or virtually, or listen to our podcasts, particularly on the 2 Saturday night firesides about, are we ready to start moving in beyond semi-quantitative biopsy in both non-cirrhotic and cirrhotic patients, where regulators will be present along with industry people and academics. And with that as a shameless plug, let me thank you tremendously for giving us your time today and being so clear about such an important topic.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please send an email to questions@surfingnash.com. Please join me again tomorrow, December 24th, for our conversation with Alina Allen.